Vanessa's leaving. She's our lead NP. It's one introductions, as she said, that she doesn't come back.
I'll be right back.
It was nice of Michelle to actually go and get us together to give us get you a little update on where we are with trauma and the expectations that we have, that you can have of us, and we can have of you as we look to move through. We've had some meetings up until this point with a couple individuals in the hospitalist side, but it's good to get together and hear it from one voice and get your questions and answers face-to-face is an important part of this process. So I'll have introductions in just a sec for Dr. Granite and Dr. Pertelli. Service goal is the same thing as your service goal, basically. We have to be friendly. We have to be nice and courteous. We want to do it in a structured manner, so it doesn't matter who the trauma team is on, who the trauma surgeon is. It's got to be structured. It has to be efficient because that's where we're all in. It's the game we're playing. We have to be, and then we have to be reproducible. So whether it's 2 o'clock in the afternoon or 2 o'clock in the morning, we have to be able to have the same quality of care. And for the most part, on the physician side, it's working well. On the nursing side, it's working well, and we'll discuss why that's working as well as it is for a program just starting out as we go forward. I want to introduce Dr. Jason Granite. He's actually our administrative director for the program, and I'll ask him to introduce his team.
Yeah, we did this because I guess we're all going to come and go. So most of you probably have met Dr. Lehow. Did you guys meet Dr. Lehow? She's a tall African-American trauma surgeon. She's the trauma director. We didn't put her picture up or my picture up because we've basically been here. And so this is Dr. Bain. He is coming tonight, this evening. He is a very well-trained trauma surgeon, and he's the nicest of all of us. He's the nicest person on the planet. It's amazing what a great person he is. He just finished his training a few years ago at Vanderbilt, which is considered one of the best trauma centers in the world. Very well trained, very good surgeon. You guys will love him, and you will ask, can we please keep him forever when you meet him. Next one is Dr. Custos. He's a little bit older. He's very talented. He trained in Louisville. He actually lives in Idaho. And he travels back and forth to come to work with this group. And so he works in where we work at the Guthrie Clinic, which is an hour west of Binghamton. And we've twisted his arm to come here for a few days, hopefully every month or so. You'll be very happy with him, too. And then Dr. Golden, he should be coming towards the end of the month. He just did finish his training a year or two ago at University of Delaware at Christiana. This is Dr. Norman. She'll be coming to in April. She just took her oral boards. So she's one of our younger trauma surgeons. And she just finished her training, her trauma at Lehigh Valley. And then Dr. Shaw, he lives in Washington, D.C. He trained up in Boston and Texas. He's coming next weekend, we hope, if the paperwork gets done. And this is Dr. Ramalingam. Dr. Ramalingam was here. He wants to be a hepatobiliary surgeon. He's helped him fill in with the trauma. He's very well trained in trauma, too. So there's this many, 6, 7, 8, and there'll be a 9th this summer who's coming, too. So the corners were all my residents. And these two, I trained for 5 years. This one I trained for 2 years only. And Rob, I trained for 4 years. So I think it speaks well that we're doing something right where we are because the people we train want to come back and be our partners. So this is our group. We're going to be in-house 24 hours a day, 7 days a week, 365 days a year. We want to take care of people who are injured. We're supposed to admit all the people who are injured. It gets a little bit, sometimes if the people are really, really elderly with all sorts of medical problems, sometimes we might put them on the hospital service, but in general, because they're probably much better served being on the hospital service when they're old and with all sorts of medical problems. But in general, patients who have injuries should come to us. Same level fall with a hip fracture or pubic rami fracture can go to the hospitalist, but anything more than that should generally be coming to us. I know there's a question of there's one upstairs who had an old C2 fracture, a compression fracture of L4. That could have gone either way. Nobody really asked me before it ended up on your guys' survey. hospitalist service. But in that case, with the dementia and everything, she's probably better off with you guys than us. So that's about it for us. Any questions? No. We'll definitely meet you guys halfway. We'll meet you halfway at least. Meeting. So. Right.
Thanks, Tom. The couple other things to add to Dr. Brandon's team. Is this the fourth system you've assisted in building out, Doc?
It's the fourth time I've been at the hospital when we started trauma. Fourth hospital I've been at. I've done a lot of locums. So I'm kind of the older ones of us. Dr. Castos, me, and Dr. Lehow. We've done a lot of locums in places we've done extra work. So for me, it's the fourth time I've been in the hospital that started trauma. I think it's doing pretty well here. I think there's a lot of support, and people are not as negative as some of the other places that I started at. So it's scary, but I think it's definitely going to raise the level for everybody. Even you guys, you're going to see. There's somebody to do surgical airway. There's somebody in the middle of the night. Hopefully, we'll do emergency surgery if we get support to do things. So if at 2 in the morning there's somebody you think is an acute admin going to need surgery, hopefully in a few months, if it works out, you might be able to call somebody to walk over and not break the meal. As opposed to, when people are at home, it's not so easy to get them. So it really might make care, more timely and efficient and easier for you guys in the future. That all depends. We have to get our nurse practitioners around the clock and everything so we can be extended. We need physician extenders to be extended. Hopefully we're going to get it. So.
Can I ask a question?
Sure.
I'm just a visitor. How many patrons is this group covering?
What do you mean?
Are these only going to be here with us at that?
No. This is not the real job for any of us. It's our second job.
Okay.
Yeah. So the decision is, and I thought it was a brilliant decision. So when you want to start a trauma program, you can go out and try to hire the trauma surgeons that are out there. But, I bet you if you try to do that, because I know some of the people that have applied for here, you're probably going to get some good ones, and you're probably going to get some very, very weak ones or people that have issues. So if you go out and try to hire the ones that are out there who are willing to come work at a new program that's not filled or anything, probably not going to get the creme of the creme. So I think this is a temporary fix, and I think this is a really smart move, because I am the trauma director there, so I know more about all these guys, and I can tell you they're all very, very, very good at the job. So I think you are getting the creme of the creme. But I am, because I think so to attract the good trauma surgeons at a place that's just starting, is almost impossible.
Right. No, I know that. I'm a surgeon too. I'm just asking. I just want to know how many places are you guys covering? It's 9, 1, 2, 3, 4, 5, 6, 7, 8.
Yeah.
How many facilities do you cover from just 2, 3, 4?
Well, so we're all at Guthrie Clinic.
Right.
Some people do locums other places. They're wrapping up that locums at other places as long as there's jobs here to support their second job. They'll all work here. Dr. Castos works a little bit in Idaho when he's there. And Dr. Bain is working a little bit in Wisconsin still. Dr. Lehow is working a little bit still in Atlantic City. But other than that, people, if there's enough work here, people will basically do it. This works for us because it's close to Guthrie, but it doesn't compete, and you don't have to get on an airplane. So for us, it fits all the things that non-compete, so it shouldn't make it to the other places that you have any argument, but you don't lose days in the commute. So it works out good for us.
Happy to have you.
Thanks.
And I believe all but one physician doctor is critically care trained as well.
Yeah, yes.
So that means that when we follow the patients through, actually through the ICU, they'll be held on to by trauma, actually until discharge, as we run through that process.
Right, we have ideas of if we get extenders, we have ideas of taking care of all the patients. Possible. Problem is, like, we're working 3 days now. If we can get down to like 2 days or however we can do it, and we have extenders, then we can probably take care of all the patients.
Where our organization actually is, as you see, the core team here is Dr. Linghouse in this position coming through. I think he just stepped out. Dr. Ian Patelli is actually the program director. I'm the manager for that registrar to handle the register stuff. Then we've got the liaisons, which by the ACS requirement, we have to have a peer review that's focused on trauma. And out of that, these are the specialties that need to be at the table for us to have monthly peer review as we go through. So, anybody worked in trauma center before? Great. So if I'm incorrect, please correct me. We weren't sure. The expectation is, as a level 2 center, is that we're going to take in everything. Everything's going to come in, and we're going to keep most of the stuff. We're an adult level 2, so the stuff that we cannot support or handle as peds will go to the appropriate peds facility. If the extreme side of the adult side, so where are we weak right now that you guys see? You know, we're a little weak in maxillofacial, a little weak in, so anything like that where we normally keep if we were strong, that might have to leave if Dr. Grant and his team find that we don't have the support.
We'll definitely have to leave. I don't make decisions on maxillofacial.
No.
So I don't want to decide that. If there's a patient who has that problem that doesn't have anybody to see it,
yes,
it's leaving.
Yeah. So that's
not trained.
That's the subgroup that if we had this specialty and it's being looked at behind the scenes for that reason, because the basic stuff, if we had the specialty, should stay. But we don't have that currently as we go through. And as Dr. Grant had pointed out in earlier conversations, earlier presentations, for the most part, we should keep just about everything that we're able to keep within our system. So why trauma? And labor intensive, sometimes collectible payer mix, and it's high acuity patients once we get ramped up. Dr. Grant kind of referenced, we've got a trauma service with acute care surgery model. That's the goal that we're looking to have as we fulfill the mid-level providers in the system and look to cover. Why is that? Well, most of the trauma patients don't require surgery, but they require a surgical focus. So if we can tie in the acute care surgery model to a surgeon that's here 24/7, and we have mid-level extenders to actually support that, we've got the best model, the most efficient approach that we can go through. It actually brings all of us up with the equipment and standards and the protocols. So already, when we've started, we've got rapid infusers in the ER that can make it to the ICU that we haven't had before. We've had a few in the as you know, in the OR, but never else within the other 2 departments. As far as accessibly ready for use, we've taken the Jane and John Doe problem that we had in the system, whether it be a code stroke or whether it be a medical emergency, in this case now a trauma. We've taken that and actually given it a unique identifier so we don't have that ambiguity when somebody's trying to look at two scans on something and they're both Jane Doe. It's a big issue, so we've corrected that. We've also corrected the merging of the medical records when you have to have a unique identifier. So when we came in, it was 3 days post-discharge that you merge somebody's old medical record. We've got that down to basically real time. And that's a systems issue, which is actually good for everybody. We want to keep our current inpatients, and I got a slide to explain why that is. So the patients we get in roughly, hair under 500 patients, we look at the data that we classify as trauma that come in here before we're a trauma center. We're looking to add to that maybe another 300-400 to ramp up to somewhere in 800 to 900 patients per year total. But we're already seeing hair under 500 of those. And then we want to receive the acuity that goes with a level 2 trauma center. And there's a lot of services here that support us. So trauma is actually a pretty good fit. We've got a good cardiovascular group, so bringing those in for anything on the thoracic side or the cardiac side is already in place. We've got a good, robust orthopedic group. Neurology and neurosurgery, we have a group, and I believe we're building on that. Those are the components that we basically need to move a trauma program forward. Now, this is a pre-hospital triage protocol. So, if we were not a trauma center, and I'm a medic in the field, paramedic in the field, which I am as a dual role, if I have somebody with a mechanism of injury with a GCS of less than 14 and or a simple pelvic fracture, they're supposed to take that to a trauma center. Mid-Hudson Regional is a trauma center. If we were not, and they want to follow the letter of the law under quality assurance, that patient should be transported there. Motorcycle crash greater than 20 miles an hour. Where does age 55 come into play? Comorbidities as we get older. So anybody 55 and older, we have to think of a heightened risk element to that. Talking with a few of you in the audience, you were receiving elderly patients with rib fractures. You were actually admitting them because there was nobody else to admit them to. That's something that we take a look to see if we needed to admit them if we think we've got an issue. So 3 or more rib fractures that come in, if it crosses your path and trauma hasn't been involved, we should get a phone call. And I've got a number here for the surgeon. Make sense? But I heard you guys were handling this before trauma came aboard. And then it's a dance to see what is the greater issue here. Is there a medical condition that's the primary diagnosis? Then it's possible that you guys would admit, and actually we would consult and monitor the rib fractures and a possible pneumo or hemo. Would we take that aboard based on the mechanism of injury and the actual injury, injuries that we have? Would we take and consult you? That's the conversation that Dr. Granite referenced. Yeah.
Are, have to do with the patient's mental status and vital signs. That's within the subset of people who have a certain mechanism of injury?
Yes.
And are the remaining things, pelvic fracture, fall, motorcycle, are those is there somewhere a comprehensive listing of things that would qualify as a...
Actually, New York State about 2 years ago, pre-hospitalized, went to the CDC guidelines. And actually, this is a CDC trauma triage protocol.
Yeah, because I mean, for us, as internists, we're totally uninitiated on what kind of a mechanism of injury qualifies to kind of get you in the higher sort of scope of what's considered trauma.
Yes.
And so, obviously, somebody who might be losing a mental status or might be in range of shock or has respiratory abnormalities is going to be a higher risk patient. Older patients is going to be a higher risk patient. And we know those things as medical doctors. What we don't know is what gets them sort of under the microscope of the trauma.
Probably a general good rule, anything other than something from a standing position, even that you might have to question, of a trauma type event. Standing, fall down, go boom, roll out of bed, go boom. Probably has some form of at least a trauma component for at least a consult to take a peek at. We see an awful lot, and not just this hospital. I was at St. Luke's, Cornwall for a while. I spent most of my life at St. Francis up there. We've got the older population that's on blood thinners. And so you get somebody that's 65, 70 years old that falls down from a standing position or strikes their head against the wall, and if they weren't on blood thinners, not as big a deal, but they are. If they weren't 65, 70, not a big deal, but they are. So now we've got risk factors involved, and we're seeing quite a few of them that develop subdurals. And if we're not cautious with that, we can actually miss that. So here's the part where we have the collaboration. If you get a call in the middle of the night to admit somebody, and there's some type of trauma event involved that you got a question, you've got a surgeon 24/7 to pick up the phone and call. Because maybe it slipped through the crack in the ED side as we go through, and maybe it didn't.
We have a real patient fell off the chair, tissue fracture, knee fracture. We were asked, this is 2 days before the trauma began. So that
That way, if you got that and we didn't consult you on it, now that would be a call to the trauma surgeon to see actually who should admit. And the trauma surgeon will pick up and talk with you. Any issues with that, I need a phone call. And we got some numbers here to give you a holler with that. Most of this, unless you're driving up, and we have a lot of good Samaritans that take their friends and drop off with stab wounds and gunshot wounds, so we do get a percentage of those, but they're small. Most of them come in pre-hospital. Pre-hospital has to follow actually the same guidelines that we actually follow. Everything is driven by the American College of Surgeons, as you'd expect. This is our Bible, and I'm constantly reminded about this from the team, is if it's in here, we have to do it. So I don't know if you caught it or not, but now we've got 24/7 in-house OR coverage. We've always had it for anesthesia. We now have it for an RN and the tech. Trauma drove that. But what happens if the middle of the night you need to get an acute belly in there and it's not trauma? Well, the team's there. Then the second team is going to come in to backfill the first team. So trauma kind of drove that, but it's going to, I think, help out the entire system, because it says we have to have capability of getting to the OR in 5 minutes if we need to, American College of Surgeons. We have to have a trauma bay that remains open. Up to this point, if a trauma came in, they'd move somebody out, bring them into any type of bay. We now have to have a trauma bay set up with the appropriate equipment that a trauma patient actually rolls into. And it's not Howard's rule, it's not Dr. Granite's rule, it's not Carly's rule, it's the American College of Surgeons rule. And a lot of you in here are probably ACLS qualified? Yeah. So same information depending on what level, right? Provider, RN, and pre-hospital. It's all the same information. It's just packaged for the scope of practice for each of the levels of care. So everybody's saying the same thing as we approach trauma. Now, pre-hospital calls in, and we've got categories, and it's based on mechanism, physiologic, and anatomic positions, and we manipulate this and change this as we think we need to. So on here is we've got a complaint of 3 or more rib fractures. Right now, we should be consulted. And then we should probably be consulted before you're consulted if it's going to be an admission. So in the future, with your person that fell down and went boom and has those, trauma should be consulted. If trauma feels that there's an issue there that we need to collaborate with you, with the hospitalists, then we'd make the phone call with you and there'd be a conversation between the surgeon and whoever's on call for you. Make sense? And these get adjusted as we find we need to focus on it. And what it does, American College of Surgeons does not like to see that we bring everybody in for everything. So we don't want the full team for a consult coming in, and I'll show you what a full team is in a second. So the level 1 is, because we're a level 2 trauma center, the team has to be at the bedside in 15 minutes. Trauma surgeon has to be at the bedside 15 minutes. Now, trauma surgeon is going to be there in a matter of minutes or prior to the patient arrival is what we want. We want pre-hospital to give us 10, 15-minute notice. We want the entire team ready to go so when they roll in, and most of these are driven by the American College of Surgeons. So ejection makes sense, blood pressure less than 90 with an issue deals with mechanism, suspected spinal cord injury if it's anatomic, all that kind of makes sense. And then chest wall instability, level 2, gives a wider time frame for the trauma surgeon to be there. The entire team is already there. So this is our team that actually shows up. On a level 1 activation, our highest, we've got anesthesia that comes down to make sure the airway is okay or doesn't need anything else to assist with. Trauma surgeon, emergency room physician, respiratories at the bedside, a minimum of 2 ED nurses, ED PCT, radiology to do either chest or pelvis if the physician requests, lab to draw the blood, security to keep those that come in with friends with gunshot wounds and stab wounds at bay if we need to, nursing supervisor, everybody below as if we need to. So if we got a leak, we ain't got to go to interventional radiology, we can go ahead and work that up. OR gives a call down to see if we have to, if we need to go directly up to the OR. Standard of care for anybody that's hypotensive with a positive belly is that they don't go to CAT scan. They actually go from, Carly will go and do a fast exam at the bedside. The fast exam is positive for excessive fluid. They're hypotensive. right up to the operating room. That's the standard of care that we're at for that type of complaint. Everybody else here is support to come through. Level 2, we drop anesthesia until we call in. So less severity. The rest of the team exists. We just had a conversation at our operations meeting yesterday. This team might actually be in play for consults as we work through this, so that we're not calling the trauma team overhead. So the surgeon's not coming, but it expedites the ER for potential cases that would have been a consult to make sure there's nothing there that's sitting in a waiting room for hours. So that's the team that comes to the bedside. And pretty good. For the most part, everybody's been within 5 minutes, not 15 minutes. So that's a positive move forward. Now, we need to be an inclusive system. So we're a level 2. We're going to shift to level 1s if we have to, Albany or Westchester. Most of the time, in my experience, it's based on where the family wants them to go. So if people live up north, they like to go to Albany. People live down here or even a little bit further south, they like to go to Westchester. If there's a specialty issue, then we got to go to the appropriate hospital. Burns, we usually ship to Westchester. We may, once we're up and running, get some transfers in from St. Luke's, Cornwall. We can get some transfers in from Kingston. We'll definitely get transfers in from Northern Dutchess Hospital as we go through that we can support. Right now, we cover, before trauma, we cover this end of the spectrum for the injury severity. We're picking up this end of the spectrum and out a little bit, and everything that we can't handle needs to go to a level 1 because of our lack of our specialties. So it's now pre-hospital has a choice to actually come to Mid-Hudson Regional or to come to us. A few caveats that we have, I believe we're already receiving thoracic cases. So I would think with the trauma side, we'd probably end up continuing with getting, if it's thoracic focus or cardiac focus. Cardiac's pretty rare in trauma. Thoracic's not so rare. We've got peds and obese. We have the specialties to at least assist us so we can package the person if we're not keeping and actually the pediatric patient or the mother and actually ship out. We just had in a mother that came in from an assault that actually went up to OB. Sadly enough, was assaulted by a significant other, and we saw her and collaborated with OB to make sure that everybody was okay in that. Similar thing to public health model, right? What the disease process is, we've got to work in prevention first, and can we correct and reevaluate to get the best outcome. We did go live on the 29th. American College of Surgeons is going to come visit us after we give them some money, 8 to 12 months after our start date. They're going to come and actually do an evaluation. They're going to give us a report card. We've got 2 years to be verified after that. The entire process is about 3 years. They want to see at least 8 to 12 months worth of data, and it's all against that orange book I talked about. A lot of quality measures that you'd expect that runs through its course. And we cover from prevention through to rehab and research. We kind of covered this. I just want to make sure I have a slide that hits some highlights. So if it's primarily a traumatic injury, we're going to cover it. We might consult you on the medical side for all the right reasons why you get consults now. If it falls into a primary medical diagnosis, we might look for you to do it, and we'll go ahead and look to consult. I believe the elderly patient, right now we're triaging very high, and that's not too bad, so we don't miss anything that we shouldn't be missing. So initial start up with a triage, over triage of 25 to 35% is not uncommon, and that's where we're at right now. We had an elderly female that fell out of bed at a nursing home, fresh post-op from hip surgery. So she came in, and the report was couldn't get a blood pressure, altered ventilation, so it was called in as a level 2 trauma. Mechanism wasn't there, but that's okay. It's going to happen until we get this worked out. I believe we took a look. There was no injury at all besides what currently was there, and I believe we talked with you and moved it over to your service. We kept an eye for the next 24 hours or so, Carly and the team, just to make sure there was nothing else going on the trauma side, and we went out from there. And the acute care surgery model Dr. Granite referenced, if you need something in the middle of the night that's acute, that needs surgery, give a call. We have collaborated and are talking with the surgeons. So if it's something that's emergent that we need to handle, and here's where the ER docs like it, is if they have an emergency airway issue that they need a surgical airway, call up, talk to the trauma doc, and come down and actually look to handle that if they need to go ahead and actually be trached. Instead of actually looking to try to call in the surgeon on call to come in to actually look to handle that. As we're working with the general surgeons, with time, as we build out the model, we're looking to support them as we need to cover general surgery call, as Dr. Granite.
We have a lot of patients in RCU or electric counseling, and usually we have emergencies like that falls off, or that are you able to help with those?
If it's something that you need a surgeon there, that you would normally need a surgeon there, you're going to call that number. And we just got it. We actually just, we're using the same model as the OR uses, as anesthesia uses. This is the 24/7 on-call phone for the in-house trauma surgeon.
This is direct line.
Yeah.
You'll get whoever's on call directly if you call that number. And if you are having some emerging issue, they will come and help you guys.
Yeah.
Eventually, we're going to support emergent surgery formally, but if in the meantime we're not quite fully on board with that, you can still call it 24/7 if you're really in trouble.
Bottom line is they're a surgeon that's in-house, and if it takes even a collaboration once they meet with you to actually collaborate with the surgeon on call, that's a better product than not including them at all on something that might need to be acutely done. So it gives you a resource as we go through. And again, we're not looking to do anything more than where we currently fit into the model as we're moving forward and having behind-the-scenes discussions with the general surgeons.
Howard?
Yeah.
A couple of related questions to that. So we don't generally like to talk about this, but every so often it does happen that somebody has a serious mechanical injury while a patient on one of our nursing units. So that would be a case that wouldn't be coming through ED, but that, that person might have received TPA, they might have died.
Call.
Yeah.
Yes.
So you guys are set up to handle, and part of the question becomes, okay, do we leave the patient where they are, and can you go into a med-surg room and do what you need to do, or what kind of groundwork might we have to lay in that situation?
There's very little that the trauma docs can't do at any bedside. It's not a room issue. It's a supply and resource issue for just assistance.
The other issue that comes up, not frequently, but when it comes up, it's a bad one, is that there are patients who are acutely ill. They're not critically ill ICU patients at the moment, but they're IV access, and they really need, or they're on acute treatments where they need continuous IV access. Happens in the middle of the night. Right now, this hospital is really without a resource in terms of when it becomes something that we know that a peripheral stick is not going to work in a lot of these patients, as dialysis patients or whatever. We don't have a go-to on somebody to do a central line on a non-ICU patient.
Do you currently use surgical services for that PA surgical services or no?
No.
Okay.
So I mean, from what I understand, this is something I tried to sort of build a model of sort of shared coverage about a year ago on this, and it's just not something that a whole lot of people are set up to do. So right now, in those situations, the sort of best next step is to white knuckle it until 7 in the morning when the team comes in.
Let me make a note, because I can't speak to that because we haven't sat down and actually addressed. It's a legitimate concern.
Do you guys ever route that through critical care?
Yes, we have, but they're and they can sometimes. Well, no, they actually. I mean, they try to help when they can, but their nighttime volume is often not such that they can come to a floor on a completely new patient with a one-off, very from the middle line. So it's a capacity issue. The only other question I had, Howard, was about burns, because I saw burns on that grid, and I didn't know if our hospital is actually, from an infrastructure standpoint, set up to take in major burns.
No, major burns are going to come in. We're going to make sure, as you would expect, that we've got a patent airway, hemodynamically stable to go to a burn center. No, we're not. And the pre-hospital folks, if it's quicker to land a helicopter for severe burns and get them out to Westchester, then that'll probably be done. If not, they'll come into here. We'll go ahead and make sure that everything, we got the basics protected, and then we're going to ship out just as quick as we actually look to get them in. The trauma and health dash quest actually goes to an email that I pick up. If it's questions that come out of that go to Carly or one of the physicians, and this is non-emergent stuff here, then I'll direct there. This is the office number. Again, it rings to the office, and then it comes over to my cell phone. This is for non-emergent stuff that you have questions or concerns on. Anything emergent needs to run to the on-call phone.
Please route all your questions or suggestions through that email. We're really trying to help build a better, not just a better service, but a better hospital. And we need everybody and all services involved to make things better. So whatever suggestions you have, please send them there. And we're trying our hardest to try and rework the system that we can. We've made a lot of changes already, and we've only hit the ground about a week between massive transfusion protocol, 24/7 OR coverage, rapid infusers being in-house for use throughout the hospital. And these are just a few things that we've started on. Working on spinal cord assessment for nursing, trying to get that in play, and massive education on how to use a collar and how to properly manage these particular patients. It's not something I think our hospital is used to.
And Carly's actually working on a respiratory response box that we're going to actually have in the ED, and if we need it in the floors, it's something we'll put out to everybody to get your input, and it might be something on the institutional side that we look to standardize. So we've got some good things on the horizon, and we're looking to support you. So you've got a good point that we need to take a look to see if you need actual emergent access on somebody that you can't get. How do we look to facilitate that?
It's a once in 2 months, 3 months occurrence that leads to 2 weeks of dialogue after it happens.
Okay. Okay. And we don't mind grabbing something that we think needs to be addressed, and that's, we're not shy for that, which is a positive deal. Any other questions? Can we stop that for just a sec?
Yeah. I'm actually going to close it.
Okay, we good?
Yeah.
Okay. I'm a glass half